the ones that you have right now.
Good afternoon, everybody. Thanks for joining. We'll get started here in a few minutes. Since our welcome and introductions and agenda review won't take too long, I am going to give it just a few more minutes just in case we get a couple more people joining.
Yeah, I'm in my office.
All right, now that it seems like less people are entering the room, we'll go ahead and get started. We'll start with introductions. My name is Sarah Smith. I'm the Provider Relations Supervisor for Yamhill Community Care. I thank you all for attending today. We are going to talk about timeliness to care standards and what that looks like for behavioral health. We're also going to talk about language access and some of the tools that we have. And then we will have time for questions. I will ask that during this meeting you remain on mute until question time, but feel free anytime to enter questions in the chat. We will have someone monitoring the chat to be able to answer some of those questions as we go along. And then we'll have our meeting wrap up and information about future forums. So with that, I'll pass it over to Deanne to introduce herself.
Good afternoon. My name is Deanne Carr, and I am the Behavioral Health and Integration Director. And I'll be talking to you a bit more about just timeliness to care, access standards, where they come from, and the who, what, whys of it all.
And then Jenna, if you'd like to introduce yourself.
Hi, good afternoon. Jenna Harms. I work in operations within Yamhill Community Care, and I'll be sharing a little bit about how to provide culturally and linguistically appropriate services and the supports that we have to be able to best serve our members' language needs.
Great, thank you. And with that, Dee Dee, would you mind putting up or Dan, did you want to put up the presentation? I can stop sharing.
Yeah, I'll go ahead and share my screen. That way the group doesn't have to listen to me saying next slide over and over again. So
perfect. Thanks, Deanne.
All right, let's see if I can make technology work for me today. There we go. Okay, so today we're going to be looking at access timelines, and I think this has sort of popped up as we've gone through the contracting process with providers, and having language within the contract that says, "Hey, these are the timelines. We're going to need to be monitoring this." And there's a couple reasons for that. Certainly, organ administrative rule, making sure that we're in compliance with that, and the CCO's obligation for monitoring and oversight. But even more important than that is the clinical implications. If someone is in emergent need, how are we doing at responding in a timely fashion and making sure that their health conditions don't deteriorate further? So as we begin to look at that, we'll go with, as I'm pushing buttons and it's not doing anything. Okay, come on. There we go. It was giving me attitude, or it could be user error, but we'll go from there. So what are the access timelines? A lot of what drives access is the 410-141 rules. And you'll see a lot of reference to those. For those of you who have been in the system for a while, it's probably worth taking a moment to talk about some changes in the access rules over time, especially within the last year to 2 years. Historically, the behavioral health access guidelines really broke it down by emergent, urgent, and non-emergent or non-urgent, which was basically routine. And so those have been in place for probably decades. And in an effort to merge and have more of a whole person approach and that integration with behavioral health and physical health, there was that attempt to then merge certain access guidelines and have a little more continuity of language. So there's been a few iterations, and I think that there was confusion regarding emergent and emergency, whereas on the behavioral health side, it was emergent. And so, provide services within 24 hours. And on the medical side, it was emergency, and it was that imminent life or death, get to the ER, call 911. And so there was initially an attempt to sort of still merge those terms, but it was found to be too confusing. So there was then that shift to using urgent in lieu of the emergent. So this is why you're going to see historically some language that speaks to urgent being within 48 hours and an emergent within 24. So if some of you have been around long enough, like myself, to have seen the two different types of language, that's sort of the origins and where that came at play. I think obviously it's good to get those languages aligned and have continuity, but it can be a little confusing, I think, especially on the behavioral health side, where sometimes there is an emergent and sometimes there is something that's more urgent, emergent, 24, 48 hours. And so clinically, we just sort of have to keep those things in mind while still having continuity with how we talk about the OARs. So as we look at this, you've got the urgent, and then within those rules, there's also you'll note under B, I just kind of outlines a variety of access timelines for priority populations. And A really speaks to all populations. B is a long line, would have taken many, many slides, and it's pretty specialized. And so it's not going to apply to everyone, but it is something that if you are more of a specialty provider, you'll want to look at. There's things such as for opiate use disorder, there's 72 hours as the access timeline for assessment and intervention. There are medication assisted treatment, or MAT, has timelines within there, timelines for pregnant women, et cetera. And so really, if you are more of a specialty provider, I would encourage you to read those directly. Routine, which is basically it's not urgent. Then they're looking for an assessment within 7 days of request. This one can be a little more difficult to track if your system doesn't have a way to show when the request was made. And there is also the client choice element of it, as far as a client may be calling for an appointment, but it doesn't work for their schedule. to take the appointment that's within 7 days. And so that's one where we expect that you're offering appointments within 7 days. We will also expect that client choice comes into play. So if somebody, if you are, 98% of the time you're meeting that, then that's not something that we're going to get concerned about, that it's not 100%, because we do understand that client choice comes into play. Now, if you're reporting, 50% of the time, then we're probably might have a few more questions about that. And this is another one that has changed. Historically, it was 14 days for routine care. And the change that they made really was driven by a lot of research and evidence base, that looking at engagement was really driven by that initial access timeline. And when you can get someone in within 7 days or less, then your engagement looks better. When you begin to exceed that, then that's where you have a lot higher rates of no-show and people disengaging and then maybe showing up later in a more acute state. Research actually shows same-day access or up to 3 to 4 days is even better, but 7 does seem to be sort of a tipping point overall as well. So as we begin to then look at, okay, well, what's urgent mean? How do I define this? Within the CCO contract, the definition just basically says it has the same meaning as 410-120 rules. So we get pointed in that direction. I'm aware I'm missing a 0 as I look up there. So it is 410-120, and then there should be 4 zeros there. Apparently I ran out of zeros. And this is where they don't speak to urgent, but rather urgent care services. And that means then, of course, that the services are medically appropriate and immediately required to prevent serious deterioration of the client's health. And they also, that tends to be a little more of a medical reference, as the rest of the sentence sort of shows that are a result of unforeseen illness or injury. That may not align as well with behavioral health as, you may have someone with schizophrenia. That's the fact that they're maybe in an urgent state is not unforeseen. But nonetheless, what we want to then perhaps look at is the 309 rules. And I know many of you were like, yay, we're talking about a lot of OARs during my lunch hour. And I know how much people really enjoy those. But I really wanted to also give you a reference if you want to do a deeper dive or want to know where it's coming from. So the 309-019 rules, those are the outpatient behavioral health rules. And so that's where if you're really wanting to do a deep dive into different specialty programs, ACT or wraparound or just your traditional outpatient services, this will give you that deeper dive. What's a QMHP? What's a QMHA? But it also speaks a bit more to urgent. What is that? And that is, there's an onset of symptoms that's requiring attention within 24 hours to prevent a serious deterioration. And so that's really anchors to how do we figure out, is this urgent? And really making those decisions about, well, is it okay to schedule something within 7 days, or do we really need to make sure that we are responding quickly to make sure that 48 hours from now, this person isn't in the ER or another adverse outcome. There's another access point. This one is not in the 410-141 rule, but it is required via the CCO contract. And I believe it's in some other rules, but I didn't find, I'm sorry, when I was putting it together, I didn't locate the OAR for you. But this speaks to, there's two pieces. One has to do with a warm handoff prior to discharge. And this language has to do with acute care psychiatric hospitals. And so if you're an inpatient provider, providing those psychiatric hospitalization, there is that expectation that you are connecting the member to a community-based provider, whether it be a case manager or their therapist or someone, but that's happening prior to discharge. And it is, while it doesn't meet the standard definition of warm handoff, the state is using it a little more loosely. And warm handoffs do tend to be more of an in-person, if you want to be very strict about the definition, but the state's definition does include more of that, the phone and things like that, but that you are in essence connecting those providers with the member. And that really gets us again to this clinical point of, if the member has been connected with someone, and it may be a new someone, maybe they're not connected with an outpatient provider, but if they've at least spoken to them, we've then increased the probability that they're going to connect with that provider after they get out of the hospital. And that is a really critical point as far as determining outcomes for this member once they're post-discharge. And the second piece of that then falls to that community behavioral health provider, which is that they provide that follow-up visit within 7 days of their discharge from the psychiatric hospital. So on the hospital's part, they need to make that warm handoff connection and help facilitate the appointment within the 7 days. So, it's always good to sort of talk a little bit about, okay, well, the why of it. Why do I need to make these access timelines? And again, it's good clinical care. That's what's driving these timelines. That's what drove the change from the 14-day to 7 days for non-routine. Really, because what are we seeing? What are we seeing that drives outcomes? What is just good patient care? And also, the blunt reality is because it's required. And, this is at the bottom of the slide, you see language that's directly from the OHA CCO contract, and really stating that contractor needs to meet and require all providers to meet. And so that's why that's underlined, is that obligation that the CCO has, that we pass that on to our providers, saying we've got to have timely access, and we've got to make sure that it takes into account the realities of the clinical presentation and of the circumstances, whether someone is a priority population or not, whether it involves opiate use, whether it, children and, their families. There's language that really talks about the most immediate access you can get for them. And again, throughout, it really is just driving, how do we have these outcomes, and how do we make sure that we're supporting our members? And I do want to acknowledge that, we are in a workforce challenge where it is hard for agencies to be fully staffed, and that there is a lot of demand, both from the workforce challenges aspect of it, as well as just the impact of the pandemic on people's mental health and substance use. And there's a higher level of need, people calling for service, and it can be hard to meet those access standards. And I think that is part of sort of larger conversations that are happening at the state level, that are happening at community level, is how do we meet those demands within a very challenging reality. And so I just kind of want to acknowledge that piece of it too. So that's sort of the overview of access, where they're coming from, why they're there. Questions? I don't know if we have any, and I'll stop sharing so we can see if there's any questions in the chat.
No questions in the chat so far. We do have about 10 minutes for questions before we move on to our next topic, but I know that we do have a time for questions and comments at the end as well. So we'll give it a few more minutes to see if anybody has questions, an eye on the chat, and then we'll move forward to our next topic.
Well, access timelines may just not have been as exciting just to trigger questions. So perhaps Jenna's presentation will be more exciting.
All
My
right, Jenna.
cue? That's my cue.
Yes, that's your cue. Just
Great.
let me know when you want me to scroll down. Is it huge on your screen? Because it's huge on mine.
Yeah, no, and this is fine. I mean, I think we can start out with this, and I'll just let you know when we're ready to scroll. That's up.
Great.
Oh, I was gonna say that was a perfect sizing.
Oh, okay. I'll move it back up then.
Yeah. So I'm just going to talk a little bit about, the provision of language assistance services. So within, as Deanne spoke to, kind of access as it relates to the delivery of service and timelines by which we need to provide service, I'm going to speak to the requirements that we have both as providers and as a healthcare system to ensure that we have appropriate, kind of culturally and linguistically appropriate services or class services, and how we can ensure meaningful language access when providing services to members. So it's a different type of access. And so really, just to kind of do a really high level level set, there are a variety of reasons that might create limitations in communication and or the ability to communicate in a language that's most appropriate. The most common that you'll hear is LEP, or limited English proficiency, which really is defined kind of more broadly, where individuals, have either based on place of birth, a culture, the languages that they grow up, or native language other than English, or that just have kind of structural abilities to communicate effectively in English. There's also kind of hard of hearing, which is kind of a loss of hearing that ranges from mild to moderate to severe, as well as people who are deaf fully and have kind of profound hearing loss, limited vision or blindness, or limited hearing or health literacy. So an individual that, really has limitations in just obtaining and processing information. So there's kind of a wide range of individuals and or limitations that our members may experience. And really our job as healthcare providers and a delivery system is to ensure that meaningful language access. So people are able to communicate in a language that is comfortable for them, and that they don't experience any additional barriers or limitations based on their care because of the need for communication. And so while that definition is simple when you think about it, I mean, the research shows that by using different types of supports, and I'll speak predominantly to using qualified healthcare interpreters, can really reduce errors as you're providing services to members. It'll enhance the quality of service and care that they receive. Improve their satisfaction as they're interacting with you during that kind of patient care experience, and reduces costs overall to the healthcare system when we're able to effectively communicate, as well as reduces any kind of adverse, in a physical health space, hospital readmissions, but really just any adverse events as it relates to care that's being delivered. So you'll scroll down just a little bit. That's perfect right there. So there are a couple drivers, and again, I won't spend a ton of time talking about, but there's civil rights, kind of federal level Civil Rights Act, Title VI, as well as within our state, the Affordable Care Act, 1557, as well as Oregon Administrative Rules, as well as the Americans with Disabilities Acts. So there's a variety of laws and regulations that really require providers, coordinated care organizations, dental care organizations to effectively provide services in a language that really preserves that access to meaningful language and meaningful communication. As I referenced before, there are these national class standards, so culturally and linguistically appropriate services, and different kind of structures that can be put in place within organizations and provider systems to ensure that effective delivery of class services. So really to provide effective care, equitable care that is really responsive to different cultural beliefs and practices, preferred language, literacy level, so their understanding and just general communication needs. There are structures to help promote and support a diverse kind of workforce and leadership within how staff are trained and deliver culturally appropriate services and linguistically appropriate services, and how within different agencies there's policies to ensure that those services are being offered and delivered appropriately. How we as providers can communicate and inform members of their rights and how to obtain services that are always at no cost to them financially, and ensure that there are high quality, so that the providers of language supports are competent and able to provide those assistance services in a high quality way. And then also just how, as an organization and as a health system, how we regulate and ensure that the policies, practices, training, all of the different activities that happen to ensure language, that those are being reviewed and assessed on a regular basis to make sure that we're meeting those needs. So if you'll scroll down just a little bit more. So I'm going to talk a little bit about kind of working with a healthcare interpreter. So there are resources available to you as a provider to ensure that if there is a language that is spoken or a communication need, whether it might be sign language and different types of interpretation, that is available through Yamhill Community Care. That is something that we can offer providers support with, as well as many providers have established systems within their practices to be able to identify members who may need language assistance support or services. So really, before you are working with a member or a patient, these are just a few tips and things to consider before a session in working with an individual. You should plan and do a few things with your patient, your client. So determine in advance if they have interpreter needs or any other type of accessibility needs. And there's a variety of different ways to be able to identify this. So this is just a high level. I'm kind of doing an overview. There is a toolkit that is available that we are actually, it's hot off the press, and we will be distributing it after this meeting today. So I'm just going to go high level, but there are a variety of different ways that you can identify an individual's needs and if they do need that support. So determine if the topics that you'll be discussing are extremely technical, or if they involve potentially kind of emotionally charged information. And then provide interpreters with as much information as possible in advance. So during a session, when you're working with an interpreter, keep in mind that you're speaking to the party or to the individual that you're working with and not the interpreter. Maintain eye contact when possible. Allow a healthcare interpreter to interpret before continuing, so giving space and time for that, as well as refraining from any side conversations with the healthcare interpreter that isn't directly on that member. So if you'll scroll down just a little bit, that's just a little bit of information in working with an interpreter. And here I think is probably the most important information that you all are probably interested in. So if I identify an individual that has a language support need, how can YCCO support you and help you to ensure that you have that access? Currently, we have a contract with Passport to Languages. This is a language service provider, and they have a variety of different kind of support services. So whether it's in-person interpreting, an interpreter, video remote interpreting, kind of telephone-based interpreting. And in order to be able to do that, to identify, you can just call and set up a number, or set up an appointment. Sorry, I was distracted with that individual coming in. We do ask that you try as much as possible to schedule in advance We do know that sometimes there is that same day need, although depending upon the language or the support need that's needed, sometimes it is more difficult to find. And so as much advance notice as possible to schedule. There is both a telephone number, a fax line, as well as on demand via an email and their website. And these services are actually billed directly to YCCO. And so this isn't necessarily an expense that the provider, you as a provider, need to take on. If you'll scroll up to the top, Sarah, back up to the top. I want to talk a little bit about coding as it relates to how you as a provider can demonstrate or show that you are providing language services.
Big issues.
Here we go. So there are codes that are available to report when you provide language services by a qualified or a certified healthcare interpreter. So there's this HCPCS code, this T1013. I don't believe there are any dental providers on, but there is also a D code for dental providers to be able to code these visits. So when you are, submitting claims and encountering essentially those services to us as a plan, we ask that you use this T code. This helps us identify that, sure enough, when you provided at service or had that encounter with an individual that did need language supports, that you were able to offer that. So I think I'm going to pause. I know I went kind of fast. I only had a few minutes, but I just wanted to kind of do a high level overview of kind of the why we try and support individuals that have language needs, a few tips and tricks, and then also there's a resource guide that can be made available that has much more detailed information.
Yeah, so when I send out the, hopefully by the end of the week, sometimes it takes a little longer because we can't send the actual recording. We have to create a link. So I hope to have the recording and these supporting documentations, as well as the toolkit, emailed to the participants by the end of the week, early next week at the latest. Like I said, sometimes it's hard to convert the recording into our online link. So if that takes longer than expected, then expect follow-up materials the following week.
One thing I would add, just, when calling for access to an interpreter, information that you might need will include the OHP number for the member. And that is different than the medical records number often within, electronic health records for folks that may be part of a larger agency. Sometimes that pops up. And so it's just a good reminder that a client may have two different identifying numbers, and making sure that you actually have their Oregon Health Plan number so that the interpretive services can confirm that they are a YCCO member. And then they also use that number for purposes of billing.
Thank you for that, Deanne. Do we have any questions at this time? I'm not seeing any in the chat. But I will leave it open for questions as this is our last topic. How is everybody doing so far in this transition? The questions that you have don't necessarily have to be on topic. They can be about almost anything. We will be having forums in the future. Our next one will be February 2nd. So keep an eye out for that invitation and what those topics look like. But we also want to hold these forums to give an opportunity to get to know our providers better, answer any questions they have, clear up any confusions there are. So please feel free to ask in the chat or go off mute, ask your questions. I'm also available via email as well through our provider relations email. So anything that comes up, please feel free to reach out to us. I will give a few minutes to allow people to answer or ask questions. And then if we don't have any within the next 5 or 10 minutes, we'll go ahead and end this early and you guys can enjoy more of your lunch.
It looks like we have a question about coding. So if I'm understanding, you are wanting us to use the code T1013 on our claim with a zero charge just for reporting. We are not actually billing for services. Is that correct? And is that only when they are using HCI, not a family member or someone else?
Yes, that's correct. So the T1013 would be a zero charge that can be reported with any visit that a healthcare interpreter, whether it's a certified or qualified healthcare interpreter. So in most cases, I mean, this may occur, but in most cases, a family member or a friend are not qualified or certified healthcare interpreters. And actually, that is something that there's a pretty big movement that's happening right now when you think of health equity and good quality care, to really kind of shy away from using family members, friends, caregivers as an interpreter. Sometimes the different content that's being discussed, may not be appropriate for family members or specifically children, to help support their family members or friends. And so we really want to, as much as possible, the member always has a choice, right? If they would like to use a family member, that is their choice. But really, we want to offer certified or qualified, so high quality interpreters, to ensure that the information that is being shared back and forth and communicated is accurate. So yes. And the code would not be used if a family member is supporting and interpreting, nor if this question came up in another discussion. If I am a healthcare provider and I speak a language that is kind of as a primary language, or I'm competent in a language that's other than English, and I'm able to provide that service, do I drop this code? And the answer is no. The T1013 code is only for those when you use a certified or qualified healthcare interpreter to support that visit. We have other mechanisms that we track. So as many of you know, you do, as when you're going through your contracting and credentialing processes, you identify if you speak any other languages. That's data that we capture, and that we can also record, and knowing that you speak those other languages and are proficient.
Okay, well, hearing and seeing no more questions, kidding. We've got another one. Oh no, it's just a thank you. Well, you're welcome, John. I'm glad that you all could attend. Thank you so much for taking time out of your lunch to come to this forum. Again, I hope to have supporting the recording and all these documents that were presented on, as well as that toolkit to you by the end of the week, early next week at the latest. If you have questions, always feel free to ask. We're always just an email away or a phone call away. And keep an eye out for our next forum, which will be February 2nd. Topics will be included in that invitation. So I will let you have more of your lunch back, and thank you all for joining our meeting today. I hope you have a wonderful day.